And then last but not least, and I don't know if she actually needs an introduction, but it's going to be Liz Crawford. And I got to know Liz about 5 years ago, I think, where we ran into each other, and she was talking about how she was not only a mother of a child with Hirschsprung's disease, but also starting to be a mother of a whole campaign about Hirschsprung's disease. And I admire her a lot for the frustration that she had and how she turned that negative energy around into something very positive to create awareness and to create information for parents. And I hope you're going to add something to that, and I think you should keep going, Liz. You're doing a great job. You're doing a great job, and we'd like to hear from your side.
Thank you. Well, first of all, I want to thank everybody for coming today. This is the first time we've done anything like this in Winnipeg. So it was really exciting for us and for our family, of course, to be able to share some of the initiatives that we have going on with Hirschsprung's disease. I thank you very much for the introduction. I had to laugh because when I was out there, Cindy said, "Richard says you're doing an app next." So I gather my work is not done. So as Richard said, our son was born in 2008 with Hirschsprung's disease. And at that time, there really wasn't a ton of information. I know that a lot of you sitting here they say that today there's not a lot of information, but at that time there really wasn't. And that's when I decided it was time for a parent forum and launched a rather controversial campaign called Shit Happens, because if you do have a child with Hirschsprung's, it either really happens or it doesn't happen, but when it does happen, usually there's something comical that comes out of that. It certainly allows you to develop a unusual sense of humor. So at that time, we launched that to raise awareness, and over the last 5 years, it's really become its own entity, which has resulted in collaborations with, Dr. Dickey and Dr. Kaiser, Dr. Goldstein that was here, and of course REACH. And REACH is actually the sponsor of today. I don't know if many of you are familiar with REACH, but it is a foundation that started in Boston by a family, the Schneidigs, whose son Adrian was born with Hirschsprung's, and they wanted to raise money to fund research. And we sort of joined forces as I was raising awareness about Hirschsprung's and developing parent platforms, and kind of, thought, okay, what can we do together? And in the last 4 years, we've funded quite a bit of research. Alan's was one of the recipients, the stem cell research, as well as other programs. I'm looking over at Kate. There's Kate Seattle. I think we gave some money last year to the pathologist in Iowa State University. So that is one of REACH's goals, of course, is to fund research for Hirschsprung's disease. The other goal is to share information that is very valuable and hard to find. So we understood that we couldn't do that solely from a parent platform, because although we all consider we're experts in our own children, we also know that every child with Hirschsprung's is vastly different. So we put together a medical advisory board. So we put all the pressure on them. It was way better. And they love getting our emails. So, and what this allowed us, though, is to have, now that we created 2 platforms, we now have the Hirschsprung's community, which serves as a parent platform, which we have utilized to gather information from families. So it's been quite useful. But we don't necessarily, the opinions that are shared there, they're not medical opinions. Purely support. But then we created another platform for REACH. And everything that goes onto there is information that has been collected either from research studies, and we always bring things back to our medical advisory board, which is a group of physicians and researchers from various hospitals and universities in North America who have a special interest or have been studying Hirschsprung's. And we pose the common questions to them. And for the most part, I'd say we have a consensus on the answers. And we try to publish that information. That way families, as well as other physicians, have a resource. Because that was one of the things that we really noted as being really important. There wasn't necessarily a standard treatment protocol from one institution to another. Families didn't really know, what to expect. So we try to answer those questions the best we can through our medical advisory board. We also, of course, through fundraising efforts and our t-shirt campaigns and the events that we have, raising money, and again, just offering that support. So that's kind of the function of REACH in the Hirschsprungs community. So as a REACH board member, and now we've just formalized Canada, so our REACH board is here, Dr. Kaiser, Cindy, Mark, Kate back there. We are really eager and excited to start funding more research in Canada, as well as, of course, putting on events and raising awareness. So thank you. I think we're going to go to the question and answer period now. And I really encourage all families, as a parent, ask questions. Even if they seem ridiculous, ask the question, because this is your opportunity. Thank you.
I can bring the mic around.
Online as well? Are we doing anything online?
I haven't had any yet, but
Okay.
I posted it up. Yeah.
Okay. You'll just check. All right. We got you.
Okay, who wants to go ahead and ask the first question?
Just raise your hand if you have a question, and I can come around with the mic.
No pressure there. Put a mic right at you.
Why does it seem that children with Hirschsprungs, as soon as they have a viral illness, it affects their gut? For example, my daughter will get an ear infection and won't poop for weeks, or get a cold and have diarrhea for a month, something like that. But my other 6 children never experienced this.
So the question is, why is it that children with Hirschsprung's disease sometimes have very long and bad diarrhea after they had another infection, like an ear infection, for instance? Yeah. Yeah. So I'm not sure if we know the real answer for that. I think we can speculate a little bit or guess what we think is going on. When you have an infection, it influences your whole body, kind of. And I personally think that the homeostasis, or the balance inside your abdomen, inside your colon, is influenced by that. So we're starting to know that there's lots of bacteria inside your colon, and those are good bacteria, right, that you need for normal life. If there's an infection like that, that might actually influence the good bacteria inside your colon, and that then might cause diarrhea. So that would influence the balance of your colon. That's a good guess.
No, I agree. And then, those are the kids that, even with an ear infection or a cold, sometimes will get enterocolitis. And I don't understand why that happens, but my guess is it's the complete change in that whole pattern or mix of bacteria. And often what I'll tell families is, those are the times, not that probiotics have been proven or not, and sometimes people actually say it hurts, but those are the times where probiotics may be useful, or yogurt with active cultures may be helpful to sort of restore that.
So you do see a similar, not as bad phenomena in children that get antibiotics for other infections. If you get antibiotics, you sometimes have runny diarrhea for a little while, and then it does help if these children take some probiotic yogurt.
But there's a bunch of groups who are doing studies about microbiomes in normal people, microbiomes in Hirschsprung's disease, microbiomes in enterocolitis. And so I think that is like one of the hot sort of things that people are actually researching into now.
So sort of following on, you guys just touched on probiotics, and I had been kind of wondering, is that something that you should just introduce as a regular part of their life, to have probiotics on a daily basis, or is that something that only if they're having a issue?
I'll go first. So I don't think we can make strong recommendations on that. I don't think the studies have been done to definitely demonstrate that it's beneficial or bad. When they were first starting to use probiotics in colon diseases. Everybody was believing this was very great and it was a new big thing to try. And then there were a few studies, and I'm from the Netherlands, and one of the big studies from the Netherlands actually showed that there might also be some severe negative side effects when you use probiotics. I don't think that's been proven in Hirschsprung's disease, but I know that's been proven in other diseases. So, as I say, I don't think there's a good study showing that you should always give probiotics in children with Hirschsprung's disease. I do think it's worth a try, like with other things in the diet, to see if your child would benefit from it.
So more if they're having issues, then use that to try and rebuild the healthy biome. Like in my son, we're thinking there might be a milk allergy, so active culture yogurt isn't an option. So maybe I could use probiotics instead.
The other problem with probiotics, like any supplement, it's not regulated and controlled. So it might not actually have what it says it has, or maybe not as much as it says it has, because that's not regulated and controlled like other medications. So you don't really know what you're getting. And there's also various types of probiotics, so we don't have research to say, well, this one works best for Hirschsprung's, this one works best for antibiotics, this one works best for Crohn's disease. So that's the other thing, is that we wouldn't really know which one to recommend, and you may not get what you think you're getting. So it's just a bit too early, I think, to make any recommendation at this point.
I only really suggest it if we've exhausted everything else. A, it's expensive, and B, it doesn't always work. I mean, if there's the first thing that really I do is what you're probably experiencing now, is eliminate milk protein. So if there's issues with ongoing abdominal distension, not tolerated feeds, and all that sort of stuff, we start with eliminating the lactose. But you'll be surprised at how much lactose there is in normal everyday stuff. And so you really have to read the labels, because even like the cookies off the counter have milk protein. I mean, and it's very hard to completely eliminate that if you're trying. You may want to add something as a dietitian.
Well, I was going to say similar to what Cindy said, was your probiotics, you never know, even from if you buy the same brand one bottle to the next, if you're giving the same thing, because of that lack of regulation on them. So while you may think you're giving something, you may not, and then spending the money to not get the outcome.
And just on that note, quickly, I'm going to ask a question, just because it keeps coming up in our group. Is there a link, and I don't think there's ever been any research that I've seen, between lactose intolerance and children with colorectal issues? No.
Not that I know of.
Not that you know of.
It's not normal to drink cow's milk.
Right.
And going through this with my own kids, and one of them having issues. I mean, there's kids who just don't tolerate it very well.
Right.
And you'll know that, even if your kid was drinking milk before, after they have a bad virus and you try and reintroduce milk, sometimes they have issues. So I don't think there's anything per se that's studied that say,
Right.
but often if you start eliminating, many kids do better.
And that is a commonality, and
Yeah.
we see it a lot coming through the community, and I certainly see it when I speak to our group. One of the first things that all of our pediatric surgeons say is, well, let's stop with the milk first and see what happens. So I was just curious if in your day-to-day.
It's actually a good thing to try and look at.
Right.
But how do you actually look at it? So I mean, at that point in time,
Right.
I think that's where the microbiome studies might be useful. Is
Okay.
on milk, off milk, enterocolitis on milk, off. All
Right.
those sort of nuances to be able to look at the makeup.
The makeup, okay. Kate, any other?
Yeah, there was just one question on social media that kept coming up with more so of adults with Hirschsprung's, and if it's possible that it could get misdiagnosed and then diagnosed in like teen years or a little bit later on.
That's you.
Yeah, so that's definitely possible. I think in what's been published, what I'm aware of, there was like a nun that was 75 that was diagnosed with Hirschsprung's disease. So it's definitely possible to be diagnosed later in life. In some areas where there's not as aggressive or good access to early health care, it gets missed after birth. And then at the same time, even in well-developed countries, Sometimes it just doesn't get recognized right away, and because it's not as clear, there's other issues going on around birth, and then it gets missed, and then the children come later to us in clinic. They have issues with constipation, and the pediatricians have tried to treat it with the normal medication that they use for that. And then at some point they say, well, we've tried everything, maybe we should also rule out that it's Hirschsprung's disease. And then we do our workup and we do biopsies, and it turns out to be Hirschsprung's disease, yeah. It's not, most common is after birth, like within the first month of life.
You have questions, Cindy? Go ahead.
Just because I'm trying to learn and our program is so infantile, I will admit, it's nice to have an expert at the table. In regards to the oral medication, and I find that oral medication can affect children in a different way and when they evacuate, when it actually hits them. So what are your recommendations for timing of taking that oral medication?
So usually Senna and Dulcolax will work about 8 to 12 hours after you give it to them. So it depends on the child, for one. I usually, when we're starting it, tell the families to take it in the morning, because then there'll be awake hours when we know it's gonna hit. And then once you know that sort of time frame, a lot of kids will take it after school or before bed, so they poop first thing in the morning. So it's variable. I have some kids who take it and they poop 3 hours later. So that's why it's hard to say, well, let's give it before bed, because you don't want them sitting in a...
So you always start first?
I start at first when we're doing our trial, and then if they want to adjust the time, we sort of keep inching the time backwards or adjusting the time when we know it's going to work. I mean, the goal of the laxatives, and we sort of mentioned this last night as well, is they exaggerate the cramping feeling, for one, so that the child who is not maybe always able to sense stool at the bottom senses that cramp, that abdominal pain, and that's their sense and clue to go poop. Plus it also gets them on a pattern, because the more patternized things are, I think it's easier for them to get clean.
Hey, where's his mic?
Are we mentioning morning? When you have a 95 success rate of like no feeling but passing stool at night, does that give you any insight? 0 success in the morning, but nighttime before bed would be the first question. Is there anything there? And the other thing is to go with a child and go regularly for a month or so, and then it's happened a number of times, and then go daily for a month, and then to 2 to 3 times a week only, but the stool is still soft, not diarrhea, but soft. So even when he does go, not hard. And is there any insight into what you think that is?
So about the pooping at night, where during the day they're clean, I think at night...
No leaking.
Yeah, so at night they relax. And so whether their baseline tone is a little bit higher, so that's where potentially sometimes something like manometry might help, because we can measure their pressures. And then when they sleep, they relax, they poop at night. Whether you can change that cycle with laxatives to try and stimulate them to go beforehand, that's something.
Not at night by accident, just at night on the schedule. You can't pass through.
You mean to schedule them at night? Oh, yeah. So then it would potentially be your timing if you're giving laxatives, what time you give the laxatives. If they're not on anything, then you may just, I mean, that's his,
That's his time.
He's
He's relaxed at night.
and he'll
that's-
poop at night.
Yeah,
But
that's-
not in the middle of the night or before
no,
bed?
He used to be, so he used
Yeah.
to always go
Yeah,
when he
so,
was asleep, when
but
he
I
was
mean,
not.
it becomes a cycle for them. So if he poops before bed, that's fine.
Yeah.
I mean, as long as they're pooping, it doesn't really matter. People like to poop in the morning. I don't,
Yeah.
because you're clean for school. I don't know, but that a lot of families like the kids to poop before school, and that's why that whole morning thing comes in. If you want the child to poop in the evening or at night while they're at home and can be relaxed, then you might give the laxatives before school. I mean, and it's so you just time it versus on life, and that's usually, and it's the same thing with enemas. There's some families who love to do it in the morning. They get up at 4:30, 5 o'clock, give them the enema so they're clean for school. some people that doesn't work for their life. They do it after school or before bedtime because that's when they have the time. And I leave it up to the families. When we do the enema trial, we do it in the morning. So that way we can get the x-ray after the enema to make sure that we cleaned you out. But once they're home, then they can switch to evenings and night times. On the day they do the switch, I actually get them to give 2 enemas. So they give 1 in the morning, 1 at night when they want to give it, and then they're on the nighttime schedule.
I think what Mark is asking, because we have the same child, so we both know, our son is that, like, if when you look at the columns and you had, well, this is this and this is this, we could sit there and go, oh yeah, he's a little column A, he's a little column B. Very, I think, typical of a lot of Hirschsprung's kids, where there's not any two that are sort of the same, right? So in our experience, we have a child who will go, all summer, as I said last night, he was doing great, but the consistency of his stool is really quite loose. So it would lead you to believe that he was having diarrhea, but he doesn't have any soiling or staining or necessarily, it's just always been loose. But then, now he's gone once in 10 days because school started. Just any little whatever seems to throw him. But so I guess your question is, how do we identify?
It will still be loose.
Yeah, even if it's been 5-6 days and it's never hard. And so I guess your question is
Not
that
diarrhea, but
when he did that one bowel movement at night, it's just always loose stool. So you're looking at the screen, and I'm looking at the screen. I know you're thinking, well, he's column A, column B.
constipation and then being very hard, and it's not the case.
Well, I mean, I don't know.
Yeah, of
But,
course.
I mean, things to consider is how much colon was there, how much colon was removed. Is there an overflow sort of thing where there is something hard sitting there and only the loose stuff is coming out. Those are all the things that we consider. The other thing is there a low-lying level of enterocolitis, because those kids will always have loose stools, and some of those we keep on a little low dose of antibiotic or flagyl, metronidazole. So it's very variable.
Yes.
On the child, and we sort of go through our checkbox list of things to try and figure it out.
Right.
That doesn't answer your question, does it?
Just like Hirschsprung, not the answer.
The problem is every kid is so different, and that's why, with our bowel management program, we can't say, oh, child A gets the same thing as child B as the same thing as child C. That's why we tailor it to the kid and we make adjustments for the kid. And a constipated kid is not the same as constipated A and constipated B because they just have different patterns. And, what does the colon actually look like in your child? Is it really distended and big and it's a dose motility issue and that's what's the problem? Or is it just one part that's big that's the problem? Or does he just have like overabundance of colon and things move really slow through it? I mean, it's so variable that and that's the hard part about some of these forums and question answer is like, because, you need that whole information to be able to make an assessment sometimes.
So just going back to something you just said in regards to low grumbling enterocolitis and the use of flagyl, because I do kind of experiment a little with that, and I do have one boy, must be 6 or 7. Once or twice a year, the mom calls me, they're out of town, and it's the same thing, doing okay, eating well, no fever, but just the tummy pain starts, some cramps. And he is stooling, so he's not sick, not too much changes. So I've thrown out a trial of flagyl, and it works every time. So now it's the standard. Once or twice a year, she calls me, there's your arbitrary 10 or 14 days. So I was going to ask you, in what situations do you find you use the flagyl, and for how long?
So I don't know what you do, but I usually, those are almost like the bacterial overgrowth kids where there's a little bit of stasis and that flips them and they get the belly pain, they get maybe a little bit distended. They're still pooping, but there's something going on, and that's why the flagyl works. And usually you try and do 2-week courses and because you don't want them on for a long time because then it stops working. So people will switch 2 weeks on, 2 weeks off. They'll switch from antibiotic to antibiotic and sort of see what works best. I don't know if you have a different answer.
No, I think that's what we do.
I just have a question. My son's on a daily dose of Restorelax, or I think it's Miralax in the States. And I've heard a little bit in the online community people saying there's concern because it's not long-term tested on young children and talk about neurologic complications and stuff. Do you guys have any concerns about that, or is there any actual, like, good studies out there talking about it?
Unfortunately, with a lot of the stuff we do in pediatrics, there's not real good long-term data. I'm not aware of any good studies showing that. I do think, though, if you look at a lot of the side effects on almost any medicine, there's always going to be these kind of things mentioned in there, because there's going to be some publication somewhere saying that they've shown some maybe effect like that. I'm not aware of any real studies and real evidence showing that long-term use of those stool softeners are giving neurological problems. Yeah.
I think there was an article in the Times or something that came out recently, or it was online, and it scared a lot of families, and we've had that question a lot. And I've talked to our gastroenterologists who use it more than I do, and they don't have any concerns about using it. The problem with pediatrics in general is you can't really test a drug in anybody younger than 18 years of age. And so there is not good evidence for safety on kids with any drug, really. And so that's where I think a lot of that stemmed from. I can't remember exactly what was quoted in that, but there was a lot of kids who had seizures, I think, afterwards. And whether that was related to something underlying, they were like case reports, so it's difficult to know the whole story.
Anything else? Okay, no, is there any other questions? Yes. Okay, or you probably have a loud enough voice. You can project, eh?
So I have a 5-year-old boy. He hasn't soiled a diaper in 6-7 months probably. His stool, when we do irrigate, is very loose. We do use Restorelax every morning, and that seems to cause so much rolling and motions. Like if you're holding him, you feel his stomach is just rumbling. Is that rolling and that motion something that could contribute to like some bloating? He does pass gas now and then, and it's usually quite nasty. But no dirty diapers, and yet when we help him, which is about every 3 days right now, it is usually very thin. There'll be air squirting out, water squirting out, and it's quite messy. And but he cannot do anything on his own. He is autistic. He is tube fed. He is on a lactose-free, pre-digested formula, and so how much of this can we do now? Is there anyone else that is working with a child like this? How do we help him? Is it painful to irrigate? Because he acts like it really hurts. He scratches himself, he pinches himself, he tries to pinch us. Is there anyone who is giving a mild sedation so that we can calm him down? Has anybody ever done something like that? That was a lot of questions.
That was a good question, though. Thank you for sharing. Belinda?
I'm going to look at you. I know the patient. So.
So nobody likes a tube up their bottom. I mean, if anybody got a tube up their bottom, I think they'd be uncomfortable. Some kids realize that the tube actually helps them, and they will comprehend that, oh, if I get an irrigation, my belly feels better, and then they're more accepting. I think when you say you're helping them poop, that means you're doing an irrigation. So you do one every 3 to 4 days, and you can't do one. More frequently. That he doesn't need it, or he.
We don't let him ever get bloated. He's never distended.
Yeah.
I asked her, have we ever thought of doing it daily? Because I've been seeing it and reading it, and.
Yeah. I mean, so Restorelax or Miralax does sometimes cause bloating in kids. I mean, the question is whether he'd do well with not just really an irrigation, or maybe an enema or a stimulant laxative to help him empty better. I mean, those are what I would potentially try to see if that would help, so you can prevent trying to do an irrigation after 4 days to get him to do something every day.
It's very complicated, and it's hard to give the answer for a group of patients. And I think in your specific case, I know your son, and as Dr. Dickey was saying, like, nobody really likes to have a tube in their bottom and then having fluid squirted in. In his case, I think what contributes to that is that he has maybe a little bit more difficulty really understanding what's going on. And that then adds to the anxiety and adds to the interaction with you, and so it makes it even more complicated. It is already very complicated if you don't have the additional components. So it's really hard to give the best answer for that. I think, like, I was sitting here thinking about it too, and there might be things that we can try and change a little bit to try and make it more comfortable, but I'm not aware, or I'm not thinking that providing real sedation might be an option as well. Like, there might be ways of taking the edge of it, but I'm not sure if that would be a solution. But I'd be happy to discuss further.
And I can tell you too from our experience with our son, he was in December, and he had a terrible bowel obstruction, and trust me, he shut down half the emergency wing just getting that out. But it's never been easy with Malachi, and he's almost 9, and we can reason with him. He will fight that tooth and nail, and it's traumatic for both him and for me, and I think probably for Cindy at that point.
And housekeeping.
So. True story. So I can tell you, but do I actually think it's causing physical trauma? No. I don't think it causes physical trauma. I think it's a reaction, it's a psychological reaction to it, and also that said too, I mean, we're always told the sphincter is quite tight. So I'm sure it's probably some discomfort. I don't doubt that. But just because he's older and he's still going through it, I can tell you what he verbalizes. And it's not so much that it's a physical thing as much as it's intrusive. And because we're insistent. And quite honestly, if I look back and think about our experience, because he's had a lot of the same things and he's almost 9, he's still to this day never really said or verbalized, I feel the urge to go to the bathroom, right? So I think back and think, gosh, I wish I had done the irrigations more frequently, because I think the time that lapsed in between in our case caused more of that resistance, and that in will. He's got some crazy will.
Well, they don't like to be held down, so that's another huge part of how traumatic it is for everybody, because you're holding them down, you're kind of forcing them. You can try and talk to them best you can. I do have one boy that's autistic, and surprisingly, and he's nonverbal, but he will go get that tube and show it to his mother. So he actually has connected using the tube with feeling better. But again, that's one case. Right. Everyone's different, so it's difficult when you're talking just maybe not about your son or a specific child, but in regards to the enemas. If you can prove that they work, then at some point you might have a discussion about, well, should we go to surgery and do a cecostomy tube? So now the tube's not up the bum, it's more normal. You're sitting on the toilet, you're putting it into the tummy tube, so that could be now less traumatic and a bit more normal because they're sitting on the toilet at a certain age. So there's always that discussion. I know different centers do different things. I think Toronto told me by the age of 5, if they'll do the enemas and then they'll just do the cecostomy. So everyone's a little bit different in their opinion, surgeon, I guess, as well, right?
Yeah. And I know with Malachi too, as I said, always loose. He's never had a really, really formed stool. And for us, the Restoralax wasn't a good choice. We used Restoralax for a long time. I still occasionally do. I start there sometimes if I think he needs it. But even me mentally, I know I have to go to something that stimulates the colon more to move that through, because I think too with him it's quite distended, and correct me if I'm wrong because I'm certainly not a doctor, but I think the more distended it is, it's the lazier it gets. It's the harder it gets to contract and move through. So then you're working both ways. You've got a colon that's kind of lazy, for lack of better words, because it's distended and not contracting in the same way. And then you've got, this loose stool, so harder to push through. So the Restorelax was, I think, is sort of counterproductive in our situation. He needs something that's really more like you suggested, Ducalax or Senna, and to really stimulate the colon and get it moving.
The problem with the colon is once it distends, it's like when you blow up a balloon and let the air out, it never goes back to its normal tone. So the longer you let it get bigger, the harder it is at some point in time for that ever to sort of come back to a normal tone.
So did that answer, I mean...
It was a
best
loosey-goosey
possible.
answer around what you're asking. I'm sorry. It's
With the formula, it's such a clean formula, he doesn't create a lot of waste.
right.
And
And but when you help him, do you get a ton of stuff out, or is it mostly gas?
No, it isn't that terribly much at a time.
And it's most.
Often it seems like often when he's been showing the most discomfort is when he gets the most air.
Yeah.
So it often is, because I'll tap the stomach and you can hear it, it's a little hollow,
Yeah.
it sounds like a watermelon. And
Yeah.
so then we'll help him, and usually there'll be a fair amount of air or bubbles that'll come out. And he, I think, does recognize what we're doing. He knows, I have a table that I made that goes over the vanity, that it's three-sided and protects so we can't fall over or anything like that. Put fresh towels down, often throw them in the garbage once we're done, but. And so he recognizes what we're doing, and we'll tell him, okay, you have to go, and he'll walk into the bathroom. But once we start, that's when the fight happens.
Yeah.
He won't fight it till then.
As far as the Restorelax, right, because his bowels are moving and stuff. And we found before, because he has sleep issues as well, that when he's getting Restorelax, it affects his sleep because his bowels are going, but he's not doing anything with it. Is there a better option that because we have stopped it and then just done suppositories before we did irrigations, which helped for a while, but now that we're trying to add in a different formula, we're trying to add in some Peptamen, we found that we've had to go back to Restorelax, but now it's affecting his sleep again. Is there something that would work better that wouldn't affect, because maybe he's just uncomfortable from his bowels moving or the gas that it's producing, so that there may be something that would work better for him that wouldn't affect his sleep as well?
Just when are you giving the Restorelax? Have you tried changing the timing of it?
We always give it in the morning.
Okay. Have you tried changing it
We used
at
to
a
give
different
it
time?
at night, and then it seemed to be worse.
Okay.
Yeah, so we've kind of tried different things as well.
Have you tried the Senna though?
No.
Or the Dulcolax, like Dr.
No, I don't think
Dickey's
we've ever been on that.
The problem is if he's mostly just gas, that's
Yeah.
not going to really help.
And what are the sleep issues? Sorry.
He's had sleep issues from when he was born. He's actually on like melatonin and a different medication as well, just so that he can get decent sleep.
Like it's disrupted. He's moving around. He's not.
He's sometimes up for a couple hours at night.
Okay.
Yeah.
I do know that Dr. Wiseman once told me this, because Malachi is not a easy sleeper by any means. Quite a bit. It's very disruptive sleep. It's quite theatrical sleep. And I remember Dr. Wiseman saying to me, well, that's for him, he's withholding gas and air all day, or he falls asleep, the sphincter relaxes, and so we see quite a lot of motion and activity. And we actually even see with him, he wakes himself up because he will sit straight up several times through the night and fold over, putting pressure on or getting on his knees and releasing the gas. So he's kind of self-soothing in the sense that he's now asleep, his body's resting, his sphincter is relaxed, and now it's like this is go time. And he actually wakes up feeling you can see the distension there's a difference, but all of that activity happened through the night doesn't make for a restful sleep for the child or you probably. Because I know it's that way in my house too. I haven't slept in almost a decade, so I get that. Okay. Any other questions? Kate, you want to check the,
Yeah, just about the ostomy bags. Some kids have them, some kids don't. So on the social media pages, we've had some stories that have come in where, you know, a woman was getting married and she was showing it off. She was, you know, proud of it. She's living with it, and some kids don't. So maybe you can just kind of touch on like when that's needed and a little bit more about that.
And how long? I know that's the question.
Yeah, how
too,
long? Like if they, how
have
long
them
they
in
need
the-
it, or why some don't, why some need it. Yeah.
I'd like to talk about a boy I know with a colostomy, and he must be 10, 11 by now, and he just had pooping issues, behavioral contributions to it, just very difficult to manage, distension, all those symptoms that we've talked about. And after long discussion with the family, they decided on trying a colostomy. And I have to say, for that boy, everything disappeared. His behavioral problems went away. The stooling was controlled. He was no longer teased. His appetite picked up. He felt great. Mom's happy. And I think he's had it at least a few years. And she said, I have no plan to take that stoma down unless he decides one day he wants to. We have another 2 children with Down's syndrome that have benefited from a stoma, and again, those parents are in no hurry to take that down because there's, you know, a lot of the behavioral problems, and it's going to be difficult with toilet training. So it does work with some families. So I think it's a discussion that you would have with your surgeon, and sort of going down all those steps when we talked about non-surgical things that we can do to try and optimize things, and then you move to the surgical things, and you know, you're going down that list to see what might benefit your child. But colostomy is a consideration, and we have a great enterostomal team here that you could meet with to have discussions about that. You know, if we were considering that, what does that look like? What does the bag look like? They use doll therapy. They're a great support system. So having that meeting as well really helps families decide if that's maybe the way they want to go. Oh, yes, we have a question.
Okay.
Yes, Rachel.
Why do you wait so long to show families that they can get a stoma and it can be life-changing instead of waiting 5 to 6 years with flushes, bowel management, bowel movement, bullying in school, where this can all be erased with a stoma?
Well, hindsight is 20/20, but maybe Dr. Kaiser wants to add something.
That's a very important question, and I can only speak from my experience with that. Is that it's very hard to predict, and we've heard in the beginning of this morning that a lot of these children will eventually get better. And then you save them a big surgery, because giving a stoma is not just a little surgery. That's a big surgery in addition to the surgery they've already had. And then potentially you give them the surgery that they might not have needed in the end. So we always try to avoid that and keep it kind of as a last resort. And we try to do all the other things first before we then move to an ostomy, because it's very invasive too. To live with an ostomy, that's not a small thing. At the same time, what you're describing is to go through all those struggles, and then the big improvement that you have after you eventually get the ostomy. That's
life changing.
yeah.
The child does it. Like Sandy told me 3 years ago, and I said, no way, I'm not going there. But we did, and it was like a whole new opening for her life, like totally life-changing.
But I know it did take you some time to wrap your head around it
Yes.
and consider it. So
Yeah, for me it took a while, but she adapted like unbelievable to the change.
But we would never rush a family into forcing that decision, saying, you need
No.
to do this.
Oh, I know.
So that's why it's a longer process sometimes.
Well, I think it's as a parent and as a physician, I mean, we all want our child to poop like everyone else poops on the toilet. And I think we project that on our kids. I think over time, and this is where the long-term studies come, and this is where feedback from parents come in, is maybe from the outset, as we get smarter, if we will or not, figure out who's going to do well with the pull-through versus who is not going to do well with the pull-through. When the baby's born, our whole thinking at that point in time is to correct things. I mean, that's what we do. We try and correct things. And of course, like we talked about, there's 3 groups of kids. I mean, some do great and never need anything, and it's hard to tell from the outset. And that's where a lot of these long-term studies, parent surveys, child surveys, patient surveys, and finding out what happens. You know, people get stomas for different reasons. And so if it's for incontinence, that's one thing. If it's for distension, that's another thing. And then that depends on how long you keep the stoma. So I think it's very patient and child dependent, and we never want to force anything on. And there are issues with stomas. I mean, we see the problems with stomas over time. So it's not that you do a stoma and things are better. I think you do a stoma at the right time and the right circumstance.
And you do that when the family and the surgeons are ready to take the risks that are associated with it. There's complications too. For like it was a very good solution for you, but there's complications from stoma placement too. So, yeah.
Are there any other questions? No? We're good? Okay, so I guess, Richard, we're...
Yeah, I'd like to thank everybody, and especially also the parents that came, and I thought it was a very good meeting. I really enjoyed being part of it, and I'd like to thank Liz and Reach and the Shit Happens campaign for facilitating and doing this.
Thank you. Thank you, everybody, for coming today, and Linda from traveling all the way from Boston, and Dr. Goldstein. So, and Richard, you're always so supportive. Thank you.